Good morning everyone. Today we are going to talk about diabetic retinopathy. Diabetic retinopathy refers to retinal changes seen in patients with diabetic mellitus. With increase in life expectancy of diabetes, incidence of diabetic retinopathy has increased and it is also a leading cause of blindness. Now talking about the etiopathogenesis, the risk factors are duration of diabetes. Duration of diabetes is the most important determining factor. It is important to note that it is the duration of disease after the onset of puberty which acts as a risk factor. So, after 10 years, 20% of type 1 diabetes and 25% of type 2 diabetes develop retinopathy, and after 20 years, 90% of type 1 diabetes and 60% of type 2 diabetes develops retinopathy, and after 30 years, 95% of both type 1 and type 2 diabetes develop retinopathy. And other risk factors are types of diabetes, age of onset, sex, poor metabolic control, heredity, pregnancy, hypertension, and in others there is smoking, obesity, anemia, and hyperlipidemia. In types of diabetes mellitus, type 1 diabetes is more likely to develop diabetic retinopathy as compared to type 2, and females are more likely to develop diabetic retinopathy as compared to male. Now let's talk about pathogenesis. Diabetic retinopathy is essentially a microangiopathy affecting retinal precapillary arterioles, capillaries, and venules produced by hyperglycemia. Hyperglycemia. Hyperglycemia refers to abnormally high level of glucose in the blood. It is commonly associated with diabetes but can also occur in other medical conditions. And the effect of hyperglycemia on blood vessels are very much significant and can lead to various complications. Now talking about the mechanism, there will be change in retinal capillaries due to hyperglycemia, and there will be hematological and biochemical changes induced by chronic hyperglycemia. The inner lining of the blood vessels is known as endothelium, and prolonged exposure to high level of glucose can impair the endothelial function, reducing its ability to regulate blood flow and maintain vascular tone. And hyperglycemia can also lead to loss of pericytes and thickening of the basement membranes by the following effects. Intracellular sorbitol accumulation, accumulation of the advanced glycation in product, activation of several protein kinase isoforms, and excessive oxidative stress due to free radicals will lead to the damage to endothelial cells, loss of pericytes, and thickening of the basement membranes. Talking about the accumulation of advanced glycation in products, when glucose reacts with proteins in the blood vessels, it forms AGEs. These compounds can accumulate and contribute to vessel damage, inflammation, and the development of complications such as diabetic retinopathy. As we all know, hyperglycemia can trigger inflammatory response and increase the production of the reactive oxygen species or free radicals in the blood vessels. So these processes promote damage to the vessels wall and contribute to diabetic retinopathy. So, due to hyperglycemia, there will be intracellular sorbitol accumulation, accumulation of the advanced glycation in products, activation of several protein kinase isoforms, excessive oxidative stress due to free radicals, which will lead to damage to endothelial cells, loss of pericytes, and thickening of the basement membranes, which will eventually lead to diabetic retinopathy. And due to hyperglycemia, there will be increasement in the platelet adhesiveness, blood viscosity will also increase, red blood cells will deform, and Rolex formation can also be seen. Serum lipids alter abnormally, there will be leukostasis, and fibrinolysis also increases. And this Rolex formation is due to the clumping of the red blood cells. Now talking about the effects of microangiopathy. Microangiopathy refers to a group of disorders that primarily affects the small blood vessels, particularly the arterioles, capillaries, and venules, and this condition can cause damage to the microvascular system, leading to various health issues. And the effects of microangiopathy are breakdown of blood retinal barrier. If there will be breakdown of blood retinal barrier, then there will be retinal edema, retinal hemorrhages, and leakage of lipids, that is hard exudates. And there will be weakened capillary walls which will produce microaneurysms and hemorrhages. And there will be microvascular occlusion also, which may lead to ischemia and its effect like cotton wool spots. Arteriovenous shunt can also be seen, that is intraretinal microvascular abnormalities. And Neovascularization can also be induced by ischemia and hyperglycemic induced oxidative stress. This ischemia and hyperglycemic induced oxidative stress will lead to release of VEGFs, PDGF and HGF that will lead to neovascularization. And neovascularization is also induced by deletion of anti-angiogenic factors like endostatin, angiostatin and PEDF. Moving on to the classification, there is non-proliferative diabetic retinopathy, that is NPDR, which is further classified into mild NPDR, moderate NPDR, severe NPDR and very severe NPDR. And there is proliferative diabetic retinopathy, that is PDR, which is PDR without high risk characteristics, PDR with high risk characteristics. And there is diabetic maculopathy and advanced diabetic eye disease. The most important classification of diabetic retinopathy is ETDRS classification, that is early treatment diabetic retinopathy study. And it is classified as mild NPDR, moderate NPDR, severe NPDR and very severe NPDR. And if there is at least one aneurysm, then it falls under mild NPDR. And if microaneurysms, intraretinal hemorrhages are present in 2 or 3 quadrants and there is early mild IRMA, then it falls under moderate NPDR. And to be under moderate NPDR, hard exudates and cotton wool spores may or may not be present. And now talking about severe NPDR, if any one of the following is present, then it falls under severe NPDR. That is, if 4 quadrants of microaneurysms and extensive intraretinal hemorrhages is present and 2 quadrants of venous bleeding and 1 quadrant of IRMA changes is present, then it falls under severe NPDR. Any one of the following, if present, it falls under NPDR, severe NPDR, and if any two of the following, these two are same, and if any two of the following are present, then it falls under very severe NPDR. Now moving on to the non-proliferative diabetic retinopathy, the ophthalmoscopic features are: there is presence of retinal hemorrhages of both deep and superficial type, that is, in deep there is blood and dot hemorrhages which is common, and in superficial there are flame sepate hemorrhages. And now talking about the microaneurysms are seen in macular area, which is the earliest detectable lesion, and microaneurysms are formed due to focal dilation of capillary walls following loss of pericytes. And there will be also presence of retinal edema, which is characterized by retinal thickening, and there will be presence of hard exudates, cotton wool spots, and there will be venous abnormalities, that is bleeding, looping and dilatations, and there will be presence of intraretinal microvascular abnormalities, that is IRMA, and there will be also presence of dark blood hemorrhages. Moving on to the proliferative diabetic retinopathy, it develops in more than 50% of the cases after about 25 years of onset, and therefore it is common in patients with juvenile onset type 1 diabetes. Now talking about the ophthalmoscopic features, there will be occurrence of neovascularization, which is the hallmark of this proliferative diabetic retinopathy, and neovascularization will be at the disc and will be at elsewhere in the fundus, that is, neovascularization at the disc is NVD and neovascularization elsewhere in fundus is NVE. And there will be fibrovascular epiretinal membrane, and vitreous detachment and vitreous hemorrhages are also present in the ophthalmoscopic finding of diabetic retinopathy, proliferative diabetic retinopathy. Now talking about the types of proliferative diabetic retinopathy without high risk characteristics and proliferative diabetic retinopathy with high risk characteristics. And now talking about the proliferative diabetic retinopathy with high risk characteristics, which is the advanced PDR, there should be presence of neovascularizations at the disc 1/4 to 1/3 of disc area with or without vitreous hemorrhages or pre-retinal hemorrhages, and there should be presence of neovascularization at the disc less than 1/4 disc area with vitreous hemorrhages or pre-retinal hemorrhages, and neovascularizations elsewhere in the fundus should be more than 1/2 of the disc area with vitreous hemorrhages or pre-retinal hemorrhages. And the risk factors for progression of non-proliferative diabetic retinopathy to proliferative diabetic retinopathy are presence of IRMAS, multiple increasing intraretinal hemorrhages, venous bleeding and loops, and the widespread capillary non-perfusion areas. Now talking about the diabetic maculopathy. Diabetic macular edema occurs due to the increased permeability of the retinal capillaries. Clinically significant macular edema is diagnosed if one of the following three criteria is present on slit lamp examination with 90 diopter lens. And the criteria are: if there is thickening of retina at or within 500 micron of the center of fovea, if there is presence of hard exudates at or within 500 micron of center of fovea associated with adjacent retinal thickening, and if there is development of a zone of retinal thickening 1 disc diameter or larger in size, at least a part of which is within 1 disc diameter of foveal center. Moving on to the clinico-angiographic classification of diabetic maculopathy, there is focal exudative maculopathy, diffuse exudative maculopathy, ischemic maculopathy, and mixed maculopathy. And in focal exudative maculopathy, it is characterized by microaneurysms, hemorrhages, macular edema, and hard exudates. And in diffuse exudative maculopathy, it is characterized by diffuse retinal edema and thickening throughout the posterior pole with relatively few hard exudates. And talking about the ischemic maculopathy, it is characterized by marked visual loss with microaneurysms, hemorrhages, mild or no macular edema, and a few hard exudates. And now talking about the mixed maculopathy, it is the combined features of both exudative and ischemic maculopathy. Moving on to the advanced diabetic eye disease, it is the end result of uncontrolled proliferative diabetic retinopathy, which is marked by persistent vitreous hemorrhages, tractional retinal detachment, neovascular glaucoma, and blindness. Moving on to the management, first of all, screening should be done, and the recommendations for periodic fundus examinations are as follows. And first examination should be done after 3 years after the diagnosis of type 1 diabetes and at the time of diagnosis in type 2 diabetes. And screening should be done in every year till there is no diabetic retinopathy or there is mild NPDR. And in moderate NPDR, we should do screening in every 6 months. And in severe NPDR, we should do screening in every 3 months. And in proliferative diabetic retinopathy with no high risk characteristics, screening should be done in every 2 months. And under investigations, we should do urine examination, blood sugar estimation, renal function test for serum creatinine, blood urea, 24-hour urinary protein, and lipid profiles should be investigated. Hemogram, glycosylated hemoglobin should be investigated. Fundus fluorescence angiography should be done, and optical coherence tomography should also be done. And under management, we should also do metabolic control of diabetic mellitus and associated risk factors by control of glycemia, control of dyslipidemia, renal function test, control of associated anemia, control of associated hypertension, and by applying lifestyle changes. Now talking about the treatment of diabetic retinopathy, intravitreal anti-VEGF drugs should be given, that is 1.25 mg of bevacizumab should be given, and intravitreal steroids of triamcinolone acetonide should also be given. And laser therapy should be done, and double frequency YAG laser of 532 nm is preferred while doing laser therapy. And under laser therapy, there is macular photocoagulation and pan-retinal photocoagulation. And macular photocoagulation is also of focal photocoagulation and grid photocoagulation. And it can be treated surgically as well by pars plana vitrectomy. Thank you.